Welcome back to our channel. In today's high yield immunology masterclass, we are decoding the celiac disease, one of the most important autoimmune gastrointestinal disorders. You will discover how a seemingly harmless dietary protein called gluten triggers a powerful immune response that damages the small intestine and leads to malabsorption. We will begin with the 33-mer gliadin peptide, an indigestible fragment of gluten that initiates the disease process. Next, we will understand why individuals carrying the HLA-DQ2 or HLA-DQ8 genes are genetically susceptible, with over 95% of patients carrying one of these HLA types. Finally, we will connect the immunology to the clinical practice by exploring the diagnosis, histopathology, serological tests, treatment, and high yield examples. By the end of this lecture, you will understand not what just happens in celiac disease, but why it happens, making this complex topic easy to remember for both clinical practice and competitive exams. So, let's get started. Let's begin with a real clinical scenario. Meet Mrs. Ananya Sharma, a 24-year-old IT professional from Bangalore. She presents with chronic loose, foul smelling stools occurring 4 to 6 times a day, along with severe fatigue for past 6 months. She also has experienced an unintentional weight loss of 5 kgs. Her mother has Hashimoto's thyroiditis, suggesting a family history of autoimmune disease. On dietary history, she consumes wheat based foods like roti and paratha every day, making gluten exposure significant. Now let's look at the laboratory findings. Her hemoglobin is 9.2 grams per deciliter and serum ferritin is only 4 nanograms per milliliter, indicating severe iron deficiency anemia that has not responded to oral iron therapy. Her total IgA level is normal, allowing reliable interpretation of the tissue transglutaminase IgA or tTG-IgA, which is markedly elevated at 112 units per milliliter. She also has positive anti-endomysial antibodies, providing strong evidence for celiac disease. Low albumin and vitamin D levels further suggest intestinal malabsorption. This combination of chronic diarrhea, refractory iron deficiency anemia, weight loss, positive celiac serology, and a family history of autoimmunity should immediately raise the suspicion for celiac disease. In the next slide, we will explore how exactly gluten triggers this autoimmune process and leads to damage of the intestinal villi. Before we discuss the correct diagnostic pathway, let's review the most common mistakes that lead to missed or delayed diagnosis of celiac disease. The first mistake is starting a gluten-free diet before testing. Once the gluten is removed from the diet, the intestinal lining begins to heal and the antibody levels decrease. This can produce false negative blood tests and biopsies, making the diagnosis much more difficult. Always test while the patient is still consuming gluten. The second mistake is labeling the patient as having irritable bowel syndrome or IBS without performing celiac serology. Symptoms such as bloating and diarrhea are non-specific, but when they are associated with iron deficiency anemia, weight loss, or chronic fatigue, celiac disease must be excluded. Third, never assume that a normal looking endoscopy rules out the celiac disease. Mild bilious atrophy may not be visible due to routine endoscopy. If clinical suspicion is high, multiple biopsies from the duodenum are essential, even when the mucosa appears normal. Finally, don't forget to measure total IgA levels. Around 2 to 3% of the patients with celiac disease have selective IgA deficiency. In these patients, the commonly used tTG IgA test may be falsely negative, so IgG based tests should be considered instead. Remember, test before treating, confirm before labeling, biopsy even when the endoscopy looks normal, and always check total IgA. These simple steps prevent misdiagnosis and ensure timely treatment. Now, let's walk through the correct diagnostic algorithm for celiac disease following the American College of Gastroenterology guidelines. The first rule is simple: never start a gluten free diet before completing the evaluation. The patient should continue eating a normal gluten containing diet so that the antibody test and biopsies remain accurate. Step 2: is the serologic testing. Order tissue transglutaminase IgA or tTG-IgA along with total IgA levels. If the patient has IgA deficiency, switch to IgG based test such as DGP or IgA or tTG-IgA. Step 3 is confirmation with the upper gastrointestinal endoscopy and duodenal biopsy. Collect 4 to 6 biopsy samples including the specimens from the second or the third part of the duodenum and the duodenal bulb. Histological examination is essential to confirm the diagnosis. Finally, in step 4, combine the positive serology and biopsy findings, such as a Marsh grade lesion, to establish the diagnosis. Only after the confirmation should the patient begin with a lifelong gluten free diet. In our case, Ananya continued eating gluten until testing was completed. Her IgA, tTG-IgA was strongly positive, total IgA was normal, and the biopsy showed Marsh grade 3B changes, confirming the celiac disease. She was then started on a strict gluten free diet. Remember, test first, confirm with biopsy, and treat only after the diagnosis is established. Now, let us understand the fascinating immune cascade that initiates the celiac disease, beginning with how gluten enters the intestinal immune system. Step 1 begins with the 33-mer Gliadin peptide. This peptide is unusually rich in proline and glutamine, making it highly resistant to digestion. Even after exposure to the gastric, pancreatic, and brush border enzymes, this fragment remains largely intact. In step 2, the intact peptide crosses the intestinal epithelial barrier. Gluten stimulates the release of zonulin, a protein that temporarily opens the tight junctions between the intestinal cells. This increases the intestinal permeability, which often is referred as a leaky gut, allowing the 33-mer peptide to enter the lamina propria where the immune cells are located. In step 3, the enzyme tissue transglutaminase 2 or TTG2 modifies the peptide through a process called deamidation. During this reaction, glutamine residues are converted to glutamic acid, giving the peptide a stronger negative charge. This modification dramatically increases the peptide's affinity for HLA-DQ2 and HLA-DQ8 molecules, setting the stage for activation of the adaptive immune response, which we will discuss in the next slide. Remember the sequence. 33-mer peptide survives digestion, zonulin opens the tight junctions, and TTG2 deamidates the peptide. After the gluten peptide has been modified by the tissue transglutaminase, the destructive phase of the celiac disease begins. In step 4, the deaminated gliadin peptide is presented by HLA-DQ2 and HLA-DQ8 molecules on antigen-presenting cells to CD4 positive T helper cells. This is a key genetic checkpoint that explains why almost all the patients with celiac disease carry one of these HLA types. In step 5, the activated T helper cells release powerful inflammatory cytokines including the interferon gamma, interleukin 21, and interleukin 15. These cytokines amplify the immune response. They stimulate B cells to produce the characteristic antibodies such as anti-tissue transglutaminase or TTG antibodies and anti-endomycin antibodies. At the same time, they activate the cytotoxic intraepithelial lymphocytes, also called IELs. In the final step, these activated IELs directly attack and destroy the intestinal epithelial cells known as the enterocytes. Repeated injury leads to crypt hyperplasia and progressive Villous atrophy, dramatically reducing the intestine's absorptive surface. This loss of villi explains why patients develop malabsorption, resulting in iron deficiency anemia, vitamin deficiencies, chronic diarrhea, weight loss, and fatigue. Remember this sequence. HLA-DQ2 or DQ8 presents the antigen, cytokines activate the B cells and the killer T cells, and intraepithelial lymphocytes destroy the enterocytes, leading to Villous atrophy. Once the immune system damages the intestinal lining, the severity of the injury is graded using the Marsh Classification, which is the gold standard for the histological assessment in the celiac disease. Let's go through each stage. At Marsh 0, the intestinal mucosa appears completely normal with intact villi and a normal number of intraepithelial lymphocytes. In Marsh 1, also called the infiltrative stage, the villi remain structurally normal, but there is an increase in intraepithelial lymphocytes, usually more than 40 per 100 enterocytes. This is often the earliest microscopic change. In Marsh 2, crypt hyperplasia develops while the villi are still preserved. Increased lymphocytes and enlarged crypts indicate ongoing immune activation. In Marsh 3A, mild villous atrophy begins. The villi become shorter and blunted, reducing the absorptive surface. In Marsh 3B, there is a marked villous atrophy with obvious shortening of the villi. This stage is commonly associated with the symptomatic disease and is often visible during endoscopy. Finally, Marsh 3C represents complete villous atrophy. The intestinal mucosa becomes almost flat, resulting in severe malabsorption and classic manifestations of the celiac disease. In our patient, Ananya's biopsy showed Marsh 3B changes, confirming the significant villous atrophy consistent with active celiac disease. Now, let us understand the laboratory tests used to diagnose the celiac disease when each one should be ordered. The first line screening test is tissue transglutaminase IgA or tTG-IgA. It has a sensitivity and specificity of approximately 95%, making it the preferred initial serologic test. However, it should always be ordered together with the total IgA. So, why do we measure total IgA? It serves as a quality control test. Around 2 to 3% of the patients with celiac disease have selective IgA deficiency, which can cause a false negative TTG IgA result. If the total IgA is low or absent, the next step is used to IgG based test such as deamidated gliadin peptide IgG or DGP IgG and tTG IgG. These are preferred alternatives in IgA deficient patients. Another important test is the anti-endomysial antibody or EMA. Although it is highly specific, it is more commonly used as a confirmatory test when the diagnosis remains uncertain. Genetic testing for HLA-DQ2 and HLA-DQ8 is not used for routine diagnosis because many healthy individuals also carry these genes. However, a negative HLA-DQ8 and DQ2 result virtually rules out the celiac disease, however, making it an excellent exclusion test. Finally, the gold standard remains the duodenal biopsy. Multiple biopsy samples are graded using the Marsh classification, which confirms the diagnosis and determines the severity of the intestinal damage. Remember, TTG IgA plus total IgA for screening, IgG based test for IgA deficiency, EMA for confirmation, HLA-DQ2 and DQ8 to rule out the disease, duodenal biopsy as the definitive gold standard. Let us discuss one of the most important exam tips in the celiac disease, the IgA deficiency trap. Imagine a 9-year-old child with chronic diarrhea, abdominal distension, weight loss, and strong clinical suspicion of celiac disease. Surprisingly, the tTG-IgA test comes back negative. Does this rule out the celiac disease? So the answer is no. The next and the most important step to measure the patient's total serum IgA level. Around 2 to 3% of the individuals with celiac disease have selective IgA deficiency. In these patients, the TTG IgA may be falsely negative even when the disease is present. So, if the total IgA level is normal, a negative TTG IgA makes celiac disease less likely. However, if the total IgA is low or absent, switch immediately to IgG based serologic tests such as DGP IgG or TTG IgG, which remains the reliable in the IgA deficient patients. If the serology is still equivocal but clinical suspicion remains high, proceed with endomysial antibody testing or an upper GI endoscopy with duodenal biopsy for definitive diagnosis. So, a negative tTG-IgA never excludes celiac disease unless total IgA is normal. Always remember the rule: order tTG-IgA together with the total IgA. If IgA is deficient, switch to IgG based test. This is one of the most frequently asked questions or tested concepts in the exams. Celiac disease is much more than a GIT disorder. In fact, many patients present without any digestive symptoms at all, making this an extraintestinal red flag extremely important to recognize. The first red flag is refractory iron deficiency anemia. If a patient, especially a young adult, has anemia that does not prove or improve the despite adequate oral iron therapy, always consider celiac disease as an underlying cause due to impaired iron absorption. The second red flag is dermatitis herpetiformis, an intensely itchy, symmetrical blistering rash typically found over the elbows, knees, buttocks, or scalp. This condition is considered pathognomonic, meaning it is highly specific for the celiac disease. Another important clue is unexplained infertility or recurrent miscarriages. Chronic intestinal inflammation and nutrient malabsorption can impair the reproductive health, and many patients improve after adopting a strict gluten free diet. In children, look for short stature or failure to thrive, especially when the growth is poor despite adequate nutrition. Sometimes poor growth may be the only sign for the celiac disease. Finally, remember the screening checklist. Even without GIT symptoms, patients with type 1 diabetes mellitus, autoimmune thyroid disease, first degree relative of celiac patients, Down syndrome, or Turner syndrome should be considered for the celiac disease screening. If you encounter unexplained iron deficiency anemia, dermatitis herpetiformis, infertility, or growth failure, think beyond the gut. Think celiac disease. Early diagnosis can prevent years of missed disease and long term complications. Untreated celiac disease is not just a cause of chronic diarrhea, it can lead to a lifelong complication affecting multiple organ systems. That's why early diagnosis and strict adherence to gluten-free diet are so important. One of the most long-term complications is osteoporosis. Damage to the intestinal villi reduces the absorption of the calcium and vitamin D, leading to decreased bone mineral density, early osteoporosis, and an increased risk of fractures, even in young adults. Another serious complication is refractory celiac disease. In these patients, intestinal villi fail to heal despite following a strict gluten free diet for at least 12 months. This condition requires specialist evaluation because persistent inflammation may indicate ongoing disease or a more serious underlying problem. Although rare, EATL, enteropathy associated T cell lymphoma, is one of the most feared complications. Suspect it if a patient who was previously improving suddenly develops severe abdominal pain, weight loss, or worsening symptoms despite good dietary compliance. Chronic intestinal inflammation also slightly increases the risk of small bowel adenocarcinoma, making long term follow up important in patients with persistent symptoms. Finally, remember that the celiac disease often clusters with autoimmune disorders. Patients have a higher risk of developing type 1 diabetes, mellitus, autoimmune thyroid disease, autoimmune liver disease, and other immune mediated conditions because of the shared genetic susceptibility. Early diagnosis and lifelong adherence to strict gluten free diet are the most effective ways to prevent the serious complications and improve the long term outcomes. Let's conclude with practical points that every clinician, when diagnosing and managing celiac disease, should know. First, the celiac belt of India, which includes Punjab, Haryana, and Delhi, has one of the highest reported prevalences of the celiac disease. This is largely because wheat is the major dietary staple. However, symptoms often overlap with infectious diarrhea, leading to delayed diagnosis, a phenomenon known as celiac iceberg, where many cases remain undetected. Next comes dietary counseling. Patients should be encouraged to eat naturally gluten-free foods such as rice, ragi, jowar, bajri, and besan. These are healthy, affordable, and readily available across India. However, hidden sources of gluten are common. Advise patients to carefully check food labels and avoid products such as soya sauce, certain hing blends, bottled sauces, processed foods, and packaged snacks, which may contain hidden wheat or gluten. The good news is that diagnostic facilities have improved significantly. tTG-IgA testing and duodenal biopsy are now available in many Tier 2 and Tier 3 cities across India. Since commercial gluten free products can be expensive, encourage patients to focus on naturally gluten free whole foods and refer them to a registered dietitian early for individualized meal planning. In India, think beyond diarrhea in patients with unexplained anemia, weight loss, infertility, autoimmune disease, or persistent GIT symptoms. Test first, confirm diagnosis, and then start a lifelong gluten free diet. Early recognition prevents irreversible complications and dramatically improves the quality of life. Now, let's wrap up this topic with the highest yield points you must remember. Here's a classic exam vignette. A patient with chronic diarrhea undergoes a duodenal biopsy that shows marked Villous shortening, crypt hyperplasia, and increased intraepithelial lymphocytes. The correct Marsh classification is Marsh 3B, which represents marked Villous atrophy. Remember this distinction. Marsh 3A is mild villous blunting, Marsh 3B is marked shortening, and Marsh 3C is complete villous atrophy. Now let's review the ultimate cheat sheet. Genetically, over 90% of the patients carry HLA-DQ2, while most of the remaining patients have HLA-DQ8. A negative result for both makes the celiac disease extremely unlikely. The key enzyme is tissue transglutaminase 2 or TTG2, which deamidates gliadin peptides, increasing their affinity for HLA-DQ2 and DQ8 molecules. The first line screening test is always tTG-IgA along with the total serum IgA. Never order tTG-IgA alone because selective IgA deficiency can produce false negative results. For confirmation, use anti-endomysial antibody or EMA when needed, but the gold standard remains duodenal biopsy with histopathological examination. The classic skin manifestation is dermatitis herpetiformis, an extensively itchy blistering rash that is considered pathognomonic for celiac disease. Finally, remember the treatment. The only proven therapy is strict lifelong gluten-free diet. There is currently no medication that cures the celiac disease. Remember this sequence: genetics, serology, biopsy, and then diet. If you recall these four steps, you will confidently answer almost every celiac disease questions in your exams. Let's finish with single most important message for the entire topic. Celiac disease begins with one peptide, the 33-mergliadin peptide. In genetically susceptible individuals carrying HLA-DQ2 and DQ8. This peptide triggers an abnormal immune response that eventually leads to flattening of the intestinal villi and lifelong gluten-free sensitivity enteropathy. But remember the golden rule: test before you treat. Never ask a patient to start a gluten free diet before completing the diagnostic workup. Removing gluten too early causes antibody levels to fall and the intestinal mucosa to heal, resulting in false negative blood tests and biopsies. The most common avoidable mistake in GIT is starting a gluten free diet before confirming the diagnosis. If you found this lecture helpful, don't forget to like, share, and subscribe. Also, let me know in the comments which Marsh stage do you find the most hardest to remember. Thank you so much for watching this complete masterclass on celiac disease. I hope this video helped you understand not just to diagnose the disease but also the immunology behind it, pathology, investigation, and clinical management. If you found this lecture valuable, like this video, subscribe to our channel, and share it to your friends and classmates preparing for the medical exams. Don't forget to leave your questions or favorite learning points in the comments. I read every comment and love interacting with you all. Until next time, Keep learning, keep growing, and remember, medicine becomes easy when you understand the concept, not just memorize the facts. Thank you, take care, and I'll see you in the next lecture.